He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Thanks for joining us, folks. It's the Stay Off My Operating Table podcast. You knew that because you clicked on that podcast, and that's why we're listening. This is Dr. Philip Ovadia's show. Phil, tell us about our guest.
Yeah, great to have Dr. Kerry Reller with us today. Kerry and I met a while ago, I'll say, lose track of time, a couple of months ago at, I believe it was the Metabolic Health Summit meeting. And it turns out that Kerry and I live fairly close to each other in the great state of Florida, and was really excited to connect with a local physician who is interested in metabolic health. And so I was excited to get her on. I got to go on Kerry's podcast a while back, and now we are flipping the table so we can get Kerry's story out there. Kerry, why don't you go ahead and give a little bit of your background to our audience, and then we'll talk about all the exciting stuff that you're up to.
Okay. Thank you so much, first of all, for having me on your podcast. I'm honored to be here. Yeah, my name is Dr. Kerry Reller. I am a board certified family and obesity medicine doctor in Clearwater and Palm Harbor, Florida, so not too far from you. And I did have the pleasure of meeting you at the Metabolic Health Conference back in January. I originally actually was an engineer in electrical engineering, and I was going to go into like biomedical engineering, thinking I would be creating the next device that you would probably be using on your patients, right? But things kind of changed when I went into the workforce, and I wanted to do something more. I wanted to work directly with people, have more engagement in helping them like live better, happy, healthier lives. Somewhere along the way, I decided to go and get my pre-medical requirements and go to med school. It wasn't completely out of the blue, although some people might think that. But so my father is also a physician, so I kind of had, medicine in the family a little bit. So it's not a total surprise that I went and did that. But I did have to get the pre-medical requirements and do that. But eventually, I found myself going in. I did med school and everything in residency, and I ended up choosing family medicine because I was very interested in sports and exercise. And so that was kind of how I fell into family medicine. And then when I was finishing my residency, my dad, who's an allergist, convinced me to move back home to Florida because I did my training in Maryland, and kind of work with him and learn allergy and asthma, and then kind of start my own family medicine practice. So I went ahead and did that. I worked under him for a few years, and it was really something was missing, I think, all along. Like, I did my senior project in exercise and the wellness of physicians, and how they did in managing our own health, because I think sometimes physicians, and when we're in our training, we kind of let ourselves go in order to help other people. So we're getting unhealthy while we're helping others. So it was one thing that really kind of bothered me, but I, did my best in residency and stuff. So I think along the pathway, with learning and doing primary care, something was missing, right? I'm looking at all these patients, every other patient I'm diagnosing with prediabetes, diabetes, and I was like, what's going on, right? So how can I better help these people to prevent them? I learned in med school to give them a medicine, do this, it's really the lack of preventative care is exactly, what we always talk about in the metabolic health space, even though I'm in preventative medicine, right? So there's something amiss in that situation. I don't know what the deal was, but I was like Googling or something during the pandemic, and I came across obesity medicine. And that's when I started to, realize that there's more to this. There is definitely a problem, not just related to, the lack of training in nutrition and exercise and fitness and things like that, but also just other things like, where was our education coming from? Was I learning all these drugs that I had to memorize, and I was not a memorizer, and just giving everybody medicine and saying that's it? I know obesity medicine, we, do learn a lot of similar things to metabolic health. And I think that kind of got me on that pathway of learning about that. And then, more recently, as I attended that conference with you, it was just like, mind blowing to me. And I've been constantly learning and researching. And I know you've had several of the guests on the podcast, your podcast, that spoke at that conference, and they're, I'm following and learning and reading all more about these things. So I wouldn't say it fell into my lap. I've always had a health, journey as well, a little different than some other people's, but I think that my role in this space is becoming pretty important because I'm really trying to focus on the patients who need help and to prevent that disease before me just, hey, here's your medicine, it's over, So that's kind of a roundabout way of kind of how I got to a little bit to where I am. I'll just stop there and see if you have any questions.
Yeah, no, that's excellent. And, kind of getting a relatively fresh perspective, right, on this as someone who's kind of new to the area will be great. But I wanted to go back a little bit. The interesting tidbit you mentioned about studying, doing a thesis or something around physicians' health. What did you learn about how good physicians are at keeping themselves healthy?
Yeah, a great question. So it was basically, are we following those exercise guidelines? So 150 minutes of moderate intensity activity, and then, or 75 of more, I guess, high intensity activity, and then the 2 days per week of weight training. And I did query my residents and fellows and the attendings, and nobody's meeting those guidelines. It was like 1 or 2 people out of everybody that we asked. And that's pretty sad, right? And I think we're all quite busy during that time, but even the attendings who aren't doing quite as much as, residents, and they're still not meeting those guidelines. So not good outcomes, really.
Yeah, no, and some of the statistics that I've seen and come across suggest that, physicians are really not any healthier than the rest of the population. And it kind of brings up the question, right? If we can't keep ourselves healthy, what chance do we have at keeping our patients healthy? And obviously, like you said, a lot that goes into that, but it should be a concern to the patients and to the physicians, because, like I said, it doesn't really speak well if the physicians can't take care of themselves. You mentioned that you kind of, dove into the specialty of obesity medicine. Talk a little bit about what you started to learn, in that environment at those conferences that, you said there's a fair amount of overlap with what metabolic health. And I guess, you went to the metabolic health conference because of maybe that overlap, but maybe talk about some of the overlap and then some of the differences that you found between the obesity medicine kind of world and the metabolic health world.
Yeah, that's a really good question. So there's also lifestyle medicine. So lifestyle medicine tends to have a very plant-based approach. And we all talk about the same things: sleep, exercise, nutrition, stress management, and lifestyle's focusing on that nutrition and more a plant-based approach. So I'm not board certified in that. And we've had discussions about that. And I think even on my podcast, I had a vegan cardiologist right after I had you on my podcast. But so that's one distinction between that. And then as far as for obesity medicine versus general metabolic health, I think the big difference is medication usage in obesity medicine. And I mean, I think that, I practice both ways. There's a role for the medications, and I think they do really help patients make these choices. But in general, we're talking about like the same pillars of making sure all these things are helping to improve our metabolic health, looking at metabolic markers that are all at risk for cardiovascular disease, for Alzheimer's disease, for, all these diseases that are somewhat preventable, right? So anything that's related to weight or obesity is usually going to be improved by improving your overall metabolic health. And I mean, obviously, a lot of this like circles around insulin resistance and diabetes. So I think that's a big crossover. But the bigger thing I think with metabolic health is you're really trying to implement those lifestyle changes with not necessarily using medications at times, whereas in obesity medicine, that we believe, or there's a lot of belief that they play a larger role, right? Whether it may be, metformin to help make yourselves more insulin sensitive, or, Contrave, which is a combined medication with naltrexone bupropion, which helps with an addiction type personality that may be something that isn't, thinking in the metabolic health space, but could really help someone with those kind of issues with, I don't know if you want to call it food addiction, that would be a whole other topic that I'm not an expert in, but that's a role for that medication. And then the other types of medication like Qsymia, which is an appetite suppressant of phentermine, combined with topiramate, which is, actually an anti-seizure drug, has also been used for a while. And then clearly in the new day and age, you can't leave out, the GLP-1 GIP agonists, which are definitely a huge topic now. And I have mixed feelings about, because, I want my patients to do, the lifestyle part, and all the studies with those medications are all shown the benefit with the lifestyle part, right? It's hard to balance of who's the right person for what, but really I'm there kind of to support the patient. But I think the biggest difference is the medication portion, I would say. Yeah.
Yeah, so you're there kind of, on the front lines, right, as in a family practice environment, and you're seeing these patients. Talk about, how you do start to balance that, right? We have the medications, and, because of our environment, right, they're all over television, they're being advertised, they're being pushed heavily. I'm sure a lot of people come in saying, I just want the medicine, right? I've been told that this medicine's going to fix my problem. I've seen the celebrity that, lost all the weight doing this medicine. And, how do you kind of approach that discussion around, it's not all about the medicine, or maybe the medicine isn't, the right thing in all situations?
Yeah, no, I definitely agree. So I will, see a patient, and, I give a little bit extra time than the average physician, I would say, so that's one thing. I have a new patient appointment, which might be 30 minutes versus someone is doing it in 15 or 20. And then if they fill out an intake questionnaire, and if it asks about weight and their trajectory of weight over time, and, issues that may be associated with that, and what they've done before, haven't done, or tried, or anything like that. And that really brings up the conversation, right? So I don't have to be the one asking about weight or saying, hey, you better lose weight, So that really helps, I think, to, set the stage for everything. And then, of course, there's going to be a patient who is coming in just for the medicine. So I'll give an example. Basically, I had a patient who, BMI of 23, wants to lose 10 pounds. And she, wanted our opinion on this. And I'm like, this is, I believe that you want to feel better, look better, be a little bit healthier, but this is not my, cup of tea. This is not something that I'm going to work with you, because I think you're healthy. I don't think you need a medication to do this. And you can do this outside. Yeah. I'm not going to be the doctor for you for that. And that's fine. And then we have another patient who really just wants to come in and do the medicine and not be part of our program. So I'll explain that more as well. And, I'm like, I go through all this insurance stuff. I have to say that you're going to be part of these lifestyle modification programs to get your medicine. And that's what I believe in. And if you don't want to be a part of that, then I don't want to be the physician writing this medicine, because you're not going to be getting the whole treatment that I think that you need in order to be healthier and be properly managed on this medicine. So I will just say, I don't think I'm the right fit for you. I will happy to see you as primary care, but if you want to get, just a medicine and that's it, I think we're not a good fit. And then there'll be someone who has tried everything possibly under the sun, who has a BMI over 40, who has really struggled their entire life with weight. I might do some genetic testing, right? Make sure nothing is being missed from a genetic standpoint of obesity. And, I will say that's a little bit rare, but I have had to do that. And then, they might be the right candidate for weight. They might need help with that food chatter, that noise, that feeling of fullness and satiety, that they're just constantly hungry. Clearly, I'm going to ask, a food history of what they're actually eating and doing. But if that's all there, I may be okay. And they're coming to me for, help and maybe the medicine, then I might say, okay, you might be a good candidate for this. This is, what we're going to do, but I'm going to monitor you at least monthly. I'm going to offer you a health coach. I'm going to do your body composition. We're going to do all these other things encompassing with it. I'm not just prescribing the medicine and letting you walk away. And I think that's a big difference than, I don't know about other areas, but our area is a huge med spa type, here's your medicine, see you later kind of thing. And I think that's a real disservice to the patients.
Phil, I'm interested in how you've got to look back on your life, but if these GLP-1 drugs have been available for you 10 years ago, how would you have responded to it?
Yeah, that's a great question. I think, and we did have other options, right? Kerry mentioned a few of the other medications that have been approved for obesity for longer periods of time. I think I always had a little bit of a skepticism, right, of the drug solving the problem approach. And one of the interesting things as a heart surgeon is one of the previous, what was supposed to be a blockbuster, miracle drug for obesity, fen-phen. If you remember that, one of the major side effects that led to it ultimately, being pulled off the market was heart valve problems. And so I saw that as a heart surgeon, and that probably, did serve to bias me against the medical approach to obesity. And, I don't know for sure what I would have done, like I said, 10 years ago, if GLP-1s came out for obesity then. But I think I did have some skepticism that probably would have kept me away from them. I mean,
well, they were available for diabetes, right?
Yeah.
So
they were available for diabetes, but no one was thinking about them for obesity back then. And, I guess, as much as I struggled with obesity throughout my life, I was always trying to do the work, right? It just turned out I was trying to do the wrong type of work. And when I started doing the right type of work around it, lo and behold, it worked. And I've been able to stick with it.
Yeah, I think that, obviously very commendable. And then, I mean, you could have had bariatric surgery too, right? Like we do sometimes partner with the surgeons for the patients who want or are candidates for that as well. So that's definitely, I didn't mention that when we're comparing to, just kind of over metabolic health versus obesity medicine. I don't think, while that changes the metabolic health for having bariatric surgery can be very helpful, and everybody's, the markers do improve and even ghrelin goes down and everything. So there's good evidence for that. I'm referring to gastric bypass, or not the lap band. The lap band, nobody does anymore. It doesn't have, the metabolic, we can have metabolic improvements, but it doesn't have the other overall ghrelin and everything improving. So
why do they not do the lap band anymore? I ask because I have a good friend who
I think the effectivity of it, and I think the complications sometimes, like people end up having to get it removed. I mean, almost everybody, there's one guy who I know has had a lap band who's been still successful and gets it tightened, but they usually ended up taking him out for most people. So they're not really doing that. And plus the bypass and the new one with the duodenal switch is like way more effective, and people do pretty well with it.
Yeah.
But to speak on what you had said about you were doing all the wrong things, I mean, there's, I've been a little bit lucky in that I've always loved physical activity and exercise, right? So throughout my life, I've had that going, but there were definitely periods where my weight went up. So I lived abroad in London in college, and I was eating bread, I was eating cheese, drinking alcohol, not moving at all compared to what I normally moved. And I gained so much weight. I came back. My parents made me join Weight Watchers. I lost a lot of weight and I did well. But during that time, I mean, I remember going to Subway. I think it was during the Biggest Loser probably, and getting a vegetarian sub because I thought I was supposed to like do not eat the protein. So I get like a big Diet Coke and a veggie sub and go running and go swimming. And, I was just in thinner, but not as strong as I think I normally would be. And I remember trying to think about going out play soccer, and I couldn't even kick the ball across the field. It was just crazy. I was thinner, but not stronger. So I don't even know. I never did labs back then, but I wonder how healthy, I might have been at the time, just thinking I was healthy eating like Subway bread. I don't know. But so anyway, I just wanted to share that as well.
It's always a much more powerful message when somebody has suffered themselves and and then has said, "Oh, I tried that. It didn't work." I mean, part of the reason Phil has so much credibility is he's an actual heart doctor.
Yeah.
But I think really bigger than that is the fact that he struggled with obesity his entire life. So when he says, "Hey, look, folks, I tried all these things. It didn't work. This is what worked." I know it from personal experience and from what I see when I'm when I'm working on somebody. And that carries a tremendous amount of authority. I have no authority in this area, partly because I have no education, but I've never struggled with my weight. Now, I can talk about problems with adrenal failure. I can talk about that from inside, what that feels, but I can't talk about this thing that's, what's the percentage, Phil? 40% of our population is obese, 80%.
I think it's a third have overweight or obesity.
I think we're right around that, but rapidly approaching. I think it's projected to hit 50% by the end of this decade in terms of the percentage of adults that are obese or overweight. And of course, the rise in this in childhood is even scarier. And that actually would be a good topic because you are a family physician. You treat across the spectrum of ages. And I don't know how much pediatric stuff you do, but I'm imagining you certainly see teenagers that are struggling with this and metabolic disease in general. Maybe talk a little bit about that.
Oh,
yeah, I don't see that many kids, but I do have kids and I can tell you a lot about that. But I do have a couple weight management patients that are are teenagers. So I think the biggest thing that we're seeing is that, kids are coming in with like fatty liver disease, diabetes, even elevated cholesterol at such young ages. And being a parent, I can see exactly why it's happening. Okay, because let me just give you an example. My kids play these sports, right? They're supposed to be going out there having fun, right? After the sports, when I was a kid, we got some orange slices and, some water maybe. Now they are getting bags full of things. Of course, a sugary drink, like a token clementine, some sort of carbohydrate thing, and sometimes even candy or a granola bar that is full of sugar and another thing, pretzels and things like that. It's just like you burn 2 calories, and not that I'm thinking of calories in, calorie out with exercise, but you burn like almost nothing, and then you're rewarded for participating with all of this food. So it's a very difficult thing to be dealing with, and going into schools and trying to educate and talk about it is definitely something that I'm interested in doing, and some other colleagues have been doing. But I don't see as many kids in general, but we're a little bit older population where my office is. But I think that, as a parent, I really can speak to a lot, and I've spoke to other parents. For instance, my kids are in an after school program, and they one day gave us this picture of all the snacks that are available for after school care. And I'm like, that's so nice that you guys are providing snacks, but could we please try to find something healthier? And, they said it has to be like packaged or whatever. And I'm like, you know what? There's not great options, but there are better options. And pretty much I was ghosted from this whole situation. And I even had other doctor parents involved, and, they just kind of shut it all down. It was very sad. So basically, I'm supposed to just have my kids not have that snack and yet provide additional snack for them so they don't eat the junk. It's like Oreos, chips.
My suggestions of beef sticks as, snacks for the kids' activities never goes over pretty well, but
my kids don't
we're
like
going to keep working at it.
Yeah. I have offered that, and I do try to do my best as well, but it is very difficult. Even the lunches available for purchase are not very healthy or balanced, and it's a huge frustration. And I can see it in other kids as they get older. The juice, the soda, that's a huge thing. And if not bringing that in and eliminating that, it's just step one. My husband grew up on orange juice. I did not. Those kind of things. I am like, no more, we're not drinking this, no more orange juice. I'm seeing like some other family members, when they bring the soda in, it's not a good situation. We're constantly trying to educate, and without creating a problem is where I find the hard line to draw there of, not creating a eating disorder, if you will, from educating enough or creating a complex about that. But it is very difficult with the kids.
I grew up earlier than either of you did. And I'm trying to think back, Little League days and YMCA basketball. I was on a swim team, and I don't remember our snacks being particularly what I would know would be healthy now. Seems like we were snacking on the same junk. But I grew up in a time, there were 800 kids in my high school, and there were two who I would say were probably more than a little overweight. I know there were two because it was so exceedingly rare. They were just clearly, obviously, huge exceptions to the rule. 2 out of 800. And I assure you, there's no way that any group of 800 kids randomly selected has only 2 who are obese today. It's one thing when we've spent decades eating poorly and not exercising and all the things that we've done. I'm overwhelmed that young kids, that it's happening so fast. And I don't get it.
I think we're learning about, there are lots of factors, right? But one of the things we're also learning is sort of the generational factor, right? Here, that parents, your mother in particular, is obese or is having, issues around high blood glucose during the pregnancy. That is just really priming the child for obesity. And then we add on the fact, that just these obesogenic processed foods are being introduced so early to these children. Baby formula, most baby formulations are high carbohydrate, vegetable and seed oils, processed stuff that we're, introducing so early. I think there are lots of things, but it's definitely, I saw an interesting meme the other day comparing, what I think most people would agree is not great food, right? Some of these snack foods or something like, white bread, right? But it was comparing the ingredients in those same foods, like in the 1970s versus the ingredients today. And it's the same food, it's the same package, it's the same name, but the ingredient lists are just completely different. The degree of the processed, all of these chemical things that have been introduced into it that, you look back, Jack, and you say, yeah, I was eating the bag of pretzels, as a snack back then, but it's probably not the same bag of pretzels, in terms of the ingredients. And that was fairly interesting to think about as well.
I'm not sure I'd use the word interesting. It's a little bit, it's alarming.
Alarming, I think is right. Kerry, we wanted to talk a little bit about, you are doing all of this in the context of, what we kind of call a traditional medical practice, right? You take insurance, you're dealing with the insurance companies. You mentioned a little earlier about, having maybe little longer appointment times than is typical. But talk about some of those challenges that you deal with around doing this in the system as it is.
Yeah, so that's definitely a great question. It's a challenge for sure. And sometimes I question why I do it, but somebody needs to help these people who have insurance and need to use it and try to get them healthier, right? The biggest challenge is not knowing when something's covered or not, and me wanting to order like a more specific test or something. So I will educate the patient, hey, this may or may not be covered, but guess what? Quest told me it's only going to be $40 total, so we can add on this. So that maybe I can add in a more advanced lipid panel for that. So I can look at some more metabolic markers like the ApoB, the lipoprotein A, the high, HSCRP, the LP little a, and the particle sizes, right? If I don't think that's available or they're not willing, then I will just do the standard lipid panel and look at the triglyceride to HDL ratio. And work with that. And then, I think fasting insulin is something I may or may not do. Sometimes I don't even find it necessary because I get the A1C and it's already high. So almost like I said, every other patient, it's prediabetes or diabetes almost every time. And then, so lab work, right? That's a little bit of a hiccup, I think, there. The other thing is answering toward their quality measures, which I think is the biggest thing, right? If I get dinged, if someone has a high blood pressure in my office, yet I want to give them time to do some lifestyle modifications in order to improve that blood pressure, right? So they'll come back and say that their blood pressure was over 140 over 90, and then I get in trouble. So sometimes I will say, okay, we're going to treat this, but guess what? You're going to get off this medication, right? We're going to go ahead and appease everybody, make sure it's in a safe range. And then we're going to work as best we can to get you off of that medication. And then, you still be in range of a normal thing. So they'll be happy, right? The other one is, every diabetic needs a statin. And then if I say someone has high cholesterol, which is almost everybody, then they're, flagging it as they need to be on a statin. And I think everybody knows how you feel about statins. So I'm trying to hold off doing some of these things, trying to educate the patient, or, I guess working with them for the next measure. So maybe I'll say, okay, here's your regular lipid profile. Your triglyceride ratio is not great. Focus on the sugar and carbohydrates. I'm not so worried about this LDL, but then we'll go back and get the advanced lipid panel next time. If that's all still concerning, maybe I'll get the coronary calcium score, which is not covered by insurance, but I've created a handout to give my patients that has all the locations and the cost to get a coronary calcium score, so we can look at that as well. Those quality measures that they require are, sometimes a little frustrating because I'm not sure I'm in complete support with them, but trying to think of some other examples. But I think those are the biggest things. And then when I do offer the longer appointment, I feel like I'm getting flagged by some of the insurance companies. Why are you always billing a 99215? I'm like, I spent that much time with them. I have to answer to like those kind of coding things as well. So that makes it a challenge. And then obviously reimbursement issues, right? So if I'm spending that extra time, there has to be a plan of how we can make a, sustainable business, right? So there are some things that I am fortunate that I get to offer the patients. In the insurance model, we also have something called remote patient monitoring. It may be the patient checking their blood pressure every day, and then we can look at it and have a call once a month to discuss anything or check in with the patient, and we can bill insurance for that. The other thing would be just checking their weight. So I put a lot of patients whose insurance covers it on a scale and check that they do that every day. And we have a way to get a little reimbursement from that, but also keep track of the patient, keep them accountable, right? Give them a little motivation. And I think that's also really helpful. And then sometimes I will order a continuous glucometer for a patient. I tell them, hey, the cash price is this, go get it. Even if insurance doesn't cover it, this can really offer you a lot of information on what's going on. For instance, this week, I'm having a guy who's struggling with reactive hypoglycemia. His A1C is 5.5. He's not diabetic or pre-diabetic, but he's eating the things that are causing him to crash. So we're taking a really deep dive in that. And it is billable to insurance. I don't know if I'm getting paid yet, but it's a way to, really look at the details of what he's doing so he can learn how to pair different foods. And when I see them, I'll suggest a certain book to read or something that might help them as well. And I think that's helpful. And then as far as like patients who I'm working with weight, we're always really dealing with the comorbidities associated with weight. So it's going to be their blood pressure, their cholesterol, their diabetes, kidney disease, anything like that. And usually we have to make those the billable codes because the insurance companies don't recognize obesity as a disease still, though the World Health Organization, I think did in 2010. Yeah, billing differently and things like that is important as well. But as far as our weight management, I did kind of move to a membership model. So they're either in those remote patient monitoring things or there is like a monthly membership fee. But with that, we are offering all of these things. And then they have like an app that we give as well and education on things to help with accountability, support, and motivation. And then we also offer health coaching. So there's a lot of companies that partner with the physicians that you can build obesity counseling codes or chronic care management codes and some other codes that can be reimbursable. And the patients really find this beneficial. Like they get their own private coach, it's televisits, and they can get a lot of support and accountability with nutrition, stress, exercise, and sleep help. And, some love it, some don't. They try for a little bit and that's okay. Not all the insurances cover it. So who does, I try to send, and who doesn't, you can have to pay cash, but I can't eat the cost of that. So they sometimes I can't offer that, but at least like we have some of these other tools to help them with, their getting those lifestyle and habit changes. And other than that, if I'm really working close with them, I'll see them like once a month. And even for the patients who I'm not in weight management for, or in my weight management program, I am looking at these labs, being very picky, and I'll tell them that. And nobody really gets offended, which is wonderful, because I always have the sense that people get offended when you say, oh, you just need to lose weight and things. I'm not saying that. I would never say that. But I'm getting picky about these labs because if we stop this problem now, you're going to be healthier down the road. So if I'm seeing an A1C, that I don't like, that isn't near pre-diabetes, but is somewhat higher, and it went up again the next time, what's different? What are you doing in your daily habits that we can fix? Sometimes I'll just be discussing their coffee, right? If it's, what are you putting in the coffee? If it's full of sugar, like creamer with sugar, let's reinvestigate that. Maybe that one thing could be it. I had one patient who was eating an entire bag of green peppermints every single day and got prediabetes. And I'm like, let's get rid of that and see how you do. And if I don't take the time to ask these questions, I probe and I probe. I'm like, what is it? Something is going on that you're doing on a daily basis that is affecting you and making you have poorer metabolic health. So let's find out what it is. Give me a food diary, something. And it really makes a difference. They'll come back and lost 10 pounds. And, that's great from one little change. It might be 6 months later, but it's a big difference sometimes. And I think that patients, really appreciate it as well. So those are some things that that I implement in our office to help with, getting a better sense of metabolic health and weight management in an insurance model, which is very difficult, as I'm sure you're aware, which is why everybody's jumping ship, as they should, to direct primary care or direct specialty care. Yeah.
The thing, as I'm listening to you, I'm thinking, Kerry doesn't sound like she's nearly as radical as a lot of the folks we talk to. And I love talking with those folks because, I'm one of those burn it all down kind of people. The thing that it sounds like that you're doing differently, aside from just kind of not having your head up your butt about metabolism, is spending time. It's that all by itself is so different than the typical experience of a patient going to a primary care physician. Who was it? I think it was Brian Linskus we talked to, who told us he was on his insurance had him on a model of, it was something like, I don't know, 6 or 8 patients an hour, just an insane number of patients. And I'm thinking, if you didn't practice medicine any differently than the average MD in America, other than just taking some extra time to listen, I think it'd make a huge difference. Now, I'm a big fan of the stuff that Phil has taught me, but kudos.
Yeah. No, time is definitely a struggle. And, I don't have all the time in the world, but I do get overwhelmed because if they are throwing more than I make sure they come in for the lab review, that's a big thing. Everything is not in green, and green doesn't always mean good. If, I'm picky about the labs and I want my patients to follow up for the lab review. But if they bring 10 problems to me with the lab review, I get a little overwhelmed and I say, okay, we'll have to discuss that next time. So there is some of that in counseling and stuff. So, I can't stay there forever, but I do try to listen and give a little more time and help them, realize these small little things that they can change can make a big difference. Yeah.
I realize I'm asking you to generalize in a situation where that might not be possible at all. But is there a common response from your patients where they are revealing a level of ignorance about health, taking care of themselves, that shows up again and again, patient after patient, that those of us who've been immersed in the metabolic health world just kind of take for granted? It's, oh my God, I forget that people by and large don't know this.
Yeah, no, I think that's very true. There's still, I think it's a generational thing too, because I have a lot of older patients who maybe baby boomers or whatever, and they just want the medicine sometimes. And there's several that aren't, but they're the exception, right? So I have some older generation ones that are an exception to the rule, but a lot of them, I've asked some people with, pretty decent bad diabetes, what if we did this or the other? There's some that are just not interested. So there's that. Then, there's definitely, everybody's still afraid of fat, and they all think the LDL is the worst thing in the world. And they all think it's all about saturated fat all the time. So there's definitely education there. And that is a hard one to get around, I think, for everybody. The biggest thing, right? Like, fat that we consume is not the fat that is on our body. Like, they're not the same thing. And that's the biggest thing that I think, I wouldn't say I even still take it for granted. It's still in the back of my head. I ate SnackWell.
Isn't that
You
weird?
mentioned it before, but I don't think that, I think that's the biggest thing. And then, the fact that some people really don't want to change, or they think that they can still include a lot of ultra processed food in the diet rather than trying to make that less ultra processed food, is just not, I don't know, sustainable. So there's a lot of education there. What are you eating? Like, these things are not good, and you really need to focus on eating, whole foods. And that's a difficult conversation too. Typically, I'm not seeing too many with financial relationship difficulties with the food. I've had a few recently, but I think that they can at least feel like they can go to the store and purchase what they want, because we're not in like a food desert or anything, and that would make it a whole different world, I think. But I've had a patient who was doing weight management. She didn't have a kitchen. She had a microwave and a mini fridge, and that was very difficult. But typically, it's the same thing, I think, is the saturated fat and the LDL myth, and then, not realizing what they're eating. It's just the food supply, trusting in the government, trusting in the food supply, believing everything that politicians, say, and things like that, having so much faith in that, when really we've been misled for so long.
I think one of the most powerful statements I heard that kind of shook me loose from my stupor about diet was, it's not fat that makes you fat. Very simple phrase, because intuitively, if somebody says, oh, all this fat is what's making you fat, it makes sense. Sure. Oh, I shouldn't eat things with fat. I need to eat lettuce and diet Doritos and diet Coke and diet, oh, what's that candy that I just cannot resist? There's the little candy corn. I tell my daughter-in-law, do not, under any circumstances, allow me anywhere in a room where there's candy corn, because I'm helpless against it. I'm going down a road I don't need to go down.
Yeah, it is interesting to hear that perspective, right? Because obviously, we have moved well past that, but it is just still so prevalent. And you're right, it's the big one that I still hear as well. And it's the one that is really one of the most challenging to get people to change their minds on, or at least be open to consider, right? Because it's really presented, and it's been presented this way for 50 years as a non-controversial fact, right? That saturated fat is bad for your health. It's going to make you fat. It's going to give you heart disease. It wasn't, we think this. It really has been presented as a well-established, fact. And we know the reality that it's not, but that's the big one. And that leads to so much more, right, about this discussion. So you really got to start at that one.
Mm-hmm. Yeah, our nutrition training, as everybody knows, in medical school is not much, and it's been funded by, or med school is funded by some other things other than who it probably should be funded by. And there's not
Your
really
nutrition class brought to you by Frito-Lay and Coca-Cola.
Yeah. Yeah.
How much nutrition training did you get?
I think we got 2 weeks, and it focused mostly on vitamin deficiencies. So it was basically rote memorization for me, and, not my cup of tea. But I think, over the years, my mom did some nutrition. I don't think she's a dietitian or anything, but she did nutrition in college or something. So I didn't grow up on white bread. I grew up, on whole wheat bread and healthier cereals until she let us buy whatever we wanted in high school. We didn't have juice, but I remember Gatorade in high school. I mean, we were playing lots of soccer and things like that. So as far as medical nutrition, I mean, really, I have, either had it in my knowledge base from growing up, but, like I said, it was flawed as well. Like I was duped by that as well when I was counting points and things like that. And but the biggest thing now is, I'm seeking out the education myself so I can teach my patients. And if you really got to find a doctor that's going to do that so they know something. And I think lifestyle medicine, obesity medicine, we're definitely on the right path. Everybody's getting better educated. So I think that's good, but you got to go out of your way to do it.
Yeah. What are some of those challenges that you see for that? What do you think the barriers are that prevent more doctors from doing this, right? Because all doctors have good intentions and want to stay educated, right? And we do the things that we think are keeping us educated, but like you said, it really does take some extra effort that you had to do, that I had to do, that so many of us have done. But what are some of the barriers that you see to doing that? Why don't more physicians do that?
I think that's an excellent question. And I believe that everybody is trying to help, everyone as well. I honestly think it may be lack of awareness that it exists. I didn't know it exists. I was in residency and I believe there was someone doing obesity medicine there, but I had no idea. I was not exposed to it. And I was like, how did I not know this existed? I wanted to do sports medicine. It's like adjacent to that, in my opinion, which is why I think I love it so much. But I just find that is maybe they just don't aware, but I think it's becoming more aware. Like the number of people board certified in obesity medicine has increased crazy in the last couple of years. I don't know if it's just because of the GLP-1 thing though. So that's, and I don't know if it's a fortunate or unfortunate thing. I don't know, but at least I think we're all learning that there's a lot of disease that is associated with weight, and weight needs to be treated as a disease. And I think that's an important thing, right? But I don't know, perhaps it's also because there's no track in, residency or med school that talks about it. I think that's bad. So how do we get doctors to do it more is, I think, just educate that it exists. I don't like more there. I will say that AAFP, the American Academy of Family Physicians, has had a lot of more CME training, I noticed, on obesity lately. So that's good. I will say that I think it's, like I said, I think geared a lot with the medications though. So I don't know. I think doctors are going to need to do this. I think the more people are coming on board. I'm part of the Florida Obesity Society, which is brand new. And we actually have a CME series, like for the next 3 Thursdays. So I was hoping to network and see who's, involved with that. But I do think it's getting better, but I'm not sure it's going to be in a role in that which we would want to see, which is more prevention rather than just treating with medication. So I do have a concern with that. But I mean, I guess that's part of my thing, like getting the word out there that you have to do your own CME. I don't even get CME for some of the stuff that I do. I'm reading books. I read your book, by the way. And I've read Steve Finney's book, and lots of Robert Lustig, and, all these people that you have on your podcast. I've probably read their books and listened to their podcasts. And I have to go out of my way to educate myself on this. And I think it's important. So I guess getting the word out will be the next step. Maybe that's what we need to do.
We're doing our
Yeah,
best.
you're right. I mean, I do think awareness is a big part of this, right? And it's kind of ironic, right? I stumbled into this at a, conference, at a Society of Thoracic Surgeons conference, but it wasn't really the main conference, content. It was just the guest speaker happened to be Gary Taubes. And, that's what kind of set me off on my exploration of metabolic health. But, for the most part, we just don't get exposed to this. Most physicians do not know that any of this really exists. It is just outside the bubble, outside the sphere. And, unless you happen to be looking for it, and that's the story we've heard over and over from the physicians we've had on this program, they were looking for it, or one of their patients, found it and shoved it down their throat, right? Because even a lot of physicians, the patient comes and they say, look at the success I've had doing this. And, the physician's just too busy to really notice or think about it. But for a few physicians, it wakes them up, it triggers something, and they go start looking, And I think, unfortunately, one of the biggest problems we have in medicine these days is curiosity is discouraged in many ways. It's kind of programmed out of us, thinking back to medical school, right? It's all about follow the guidelines and memorize these facts, and don't really think about, whether or not that might be true, or whether there might be other facts out there. Really, just it's all sort of discouraged in medicine these days. So I certainly congratulate you for being curious and doing this and thinking about these other things, and just trying to think about different ways to help your patients.
I appreciate that. I was going to say, we didn't really mention functional medicine, but I think partnering with doctors, the functional medicine providers, or, some are doctors, some are the alternative type doctor. I think that shows a lot too. I remember when I walked in that conference with all the vendors and stuff, they're like, you use insurance? What? This was like totally crazy for me even to be there for that. They were so confused. But a lot of, the functional doctors out there, have a lot of offering too. And I think maybe partnering with them, like I've tried to do a little bit myself, is very helpful too, because I think they have a lot to offer, a different role. I've thought of doing some of that myself, but time. So I think that would be a helpful way to also, educate, get the word out as too.
Yeah, certainly.
All right.
This has been a great discussion. Very interesting, different perspective than we've gotten previously. So glad I ran into you at that conference, and that we've been able to talk and stay in touch since then. For people that want to find more about what you're doing and find your practice, let them know how to do that.
Yeah, it's called Clearwater Family Medicine and Allergy. And we're in Clearwater and Palm Harbor. Our website is www.cfma.health. And phone number is 727-446-1097. And on Instagram, Clearwater Family Medicine. And yeah, you can find me there. And I'm sure you'll put all the rest in the show notes and things like that. Thank you so much for having me on. This was a lot of fun talking to you guys about everything in the, insurance-based world and whatnot. Thank you.
We appreciate you. For Dr. Philip Ovadia and Dr. Kerry Reller, this has been Stay Off My Operating Table. All the contact information that you heard here will be in the show notes. We'll talk to you next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.